Hello, and welcome to The Journey Continues, where we explore the stories, the facts, and the incredible impact of organ donation and kidney health. I'm Sarah Jane Charles.
And I'm Monica Fox. Each month, we'll honor individuals who gave the gift of life through organ donation, learn from experts, and explore how the National Kidney Foundation of Illinois can help you protect your kidney health. Let's head right into our first segment, Donor Spotlight.
John Beach II was gifted with the talents of building and fixing. He could look at something and figure out how to pull it apart, put it back together, and leave it better than he found it. A skill that helped him pursue his passion for motorcycles.
Unfortunately, just hours after his 22nd birthday, John was in a catastrophic motorcycle accident. His lifelong friend, Amanda, witnessed the accident and administered CPR, allowing him to make it to the hospital alive.
Everyone in John's family is a registered organ donor, and he was no exception. After his doctors determined he was brain dead, he donated his organs, saving 6 lives in his passing.
His lungs went to one recipient, his kidney and pancreas to another, his liver, heart, and corneas to 3 others. Bone and skin grafts and his tendons went to over 150 other recipients.
His family says the fact that organ donation was an option for John means that he's still living on this earth. When they spread his ashes in Palisades Park, an eagle flew overhead twice before flying away, and his family says it was as if he was telling us he made it to heaven and we shouldn't worry about him.
After his passing, John's family founded the John A. Beach II Memorial Foundation. The foundation is designed to promote organ donation awareness and to help other families cope with the loss of a loved one.
His family also holds a memorial motorcycle run and plans to hold fundraisers for organ and cornea donation awareness in the future.
John was a kind and giving young man. He would go out of his way to help others. Organ donation allowed him to keep helping others and add his compassion to the world. Thank you to my friends Joy and John for sharing his story with us.
On the other side of a short break, the journey continues with Ask the Expert, featuring renal transplant coordinator Anita Pacrassi and living kidney donor Dan O'Connell. Stay with us.
Welcome back. Our guests today are Anita Pacrassi, registered nurse and renal transplant coordinator at UI Health, and Dan O'Connell, living kidney donor and clinical psychology doctoral student at the University of Houston.
Anita, Dan, thank you so much for joining us on The Journey Continues.
Thank you for having us.
So Anita, I want to start with you. What does a renal transplant coordinator do?
Well, that is a loaded question. So there are many renal transplant coordinators in a given program, and there are different segments of the transplant journey for which each coordinator would be assigned. So I personally work up living donors, I evaluate them, I work up their recipients to make sure that the recipients are good candidates to receive a transplant. We then have waitlist coordinators who manage patients who are already listed and approved, because every year they have to come back and have a little update to make sure they remain a candidate. So that's a different category of coordinator. Then you have cadaveric coordinators who do not work with living donors at all. They just work up the recipients who do not have live donors. But they also play a big role in educating their patients on the benefits of living donation, with the hopes that they will, eventually identify a live donor. And they are involved in listing the patients with UNOS, which, as some of you might know, is the United Network for Organ Sharing, where all transplant recipients and donors must be listed before they can go on to have their surgeries to donate or receive a kidney. Then you have the changing of the guard from the pre-side of the journey to the post-side of the journey. And so then you have the post-transplant coordinators, which I did that for many years as well. I think I've done like almost every role in all the many years that I've been a nurse coordinator. But then you have post-transplant coordinators who help manage they do clinical management of the patient's post-transplant, which has a lot to do with adjusting medications along with the physicians and the medical team, filling prescriptions and, clinically, like seeing the patients in the clinic, managing issues that they may be having. So that's a whole other role. And within that group of post-transplant coordinators, you can have what we call acute coordinators that just follow the patients for the first year after transplant when you would expect the most potential complications to occur. And then you have the chronic post-transplant coordinators who then manage the patients further out. And eventually patients are usually graduated to their local referring nephrologist or a local, doctor to take care of them, and we're sort of cut the umbilical cord eventually, and we're just there for, for if they have a problem or something, they need to come back. But we kind of follow them peripherally at that point. Okay. So when you ask, what is the role of a transplant coordinator? It depends, because there's many different roles.
A lot of hands on deck.
Yeah, yes. And that's what I love about the field, because there are so many, areas you could work in. Oh, and I forgot about quality coordinators. So in every transplant program, you have coordinators who are not really working directly with patients, but they're making sure that all the regulatory responsibilities are met, like with documentation, with when blood is drawn. UNOS and CMS have a lot of rules and regulations, and they change all the time. And so they keep track of all of that and make sure that all of us are doing things the right way, meeting all those requirements. So there's the whole quality team on top of that. Wow. Then you have a research team, do transplant research. So transplant is a very broad field, and for nurses, there's a lot of different areas that you could work in.
Okay, wow.
Yeah.
Well, thank you for that thorough explanation of transplant coordinators. That is, we're grateful to have that information.
Wonderful.
So now we want to talk about your role as a living donor coordinator, and what medical and psychological testing do people go through in order to know if they're eligible to be a living donor?
So every center may be slightly different, but the overall thing that we're trying to find out is the same. And so, going from point A to point B, different centers may do, different little pathways, but eventually all the tests lead to, yes, you qualify, or no, you don't qualify. So there is probably the most important thing to do is to screen your donor candidate first. So, donor candidates will call, they will register, and then we will do a phone interview where we do a full, thorough medical history, family history, social history. What vices do they have? Have they done drugs? Do they smoke? Do they drink a lot? Do they have, are they on medication for a behavioral health issue or a psychological issue? Is it controlled? Do they have any chronic illnesses that would disqualify them, such as, for example, uncontrolled hypertension or diabetes on insulin or something like that? There are certain conditions that would be like absolute contraindications, but we still encourage every potential person who wants to donate to call in and get the screening done, and don't try to decide for themselves if they're a candidate or not, because different centers have different criteria. Like, for example, at the University of Illinois where I work, we accept donors with the body mass index up to 45. Some centers only accept up to 40 or 35. So some centers are more aggressive, more liberal with their donor acceptance criteria. So all donors should definitely be encouraged to call in, get the screening done at the particular center where they want to donate, and if there's no obvious red flags, like, for example, an obvious red flag would be somebody who just was diagnosed with breast cancer and is getting chemotherapy, for example. Somebody with active cancer, that's not in remission for some period of time would not obviously be a candidate. So, we go through the interview, we find out the red flags, and if there's no red flags, then the patient starts the actual evaluation process, which involves a lot of blood work, where we test for many different things, their blood type, obviously, their genetic thumbprint, I like to say, or fingerprint, which is the type of proteins that are on the surface of their cells that could cause the recipient to possibly reject. So we test for that. We test their kidney function, their liver function, their blood counts, all kinds of viral infections, different other types of infections. Just want to make sure they're overall a healthy person. So we do the screening labs, and if those look good, then they come in and they meet the entire transplant team, which is usually about 6 people, sometimes 7. For donors who are altruistic, anonymous donors at our center, they all have to have an additional consult with an ethicist to make sure that they're donating. I don't know if you had to have that when you donated, but so there's a surgeon, a nephrologist, which is a kidney specialist, the coordinator, who we do a lot of the education with the donor candidate, there's a social worker, there's a dietitian, and there's a living donor advocate. So that's 6, and then sometimes there's 7, which is the ethicist. So they have all the consults. They do a test to find out how well their kidneys actually function. Do they have a high enough function to actually give up 1 kidney? So at our center, we do something called an iohexol GFR. Other centers use a nuclear medicine scan or a 24-hour urine collection. So, you know, from center to center, it may differ, but it's all coming to that same conclusion. Does the patient have enough function with 2 kidneys to give up 1? And when you give up 1 kidney, this kidney will compensate and regain maybe 25 to 30% of the function of the kidney that was removed in most cases. So, so we do that kidney test, which is very important. And then depending on the age of the donor and the history of the donor, there's additional testing, cardiac testing. Everybody has an EKG, a chest x-ray, sometimes an echocardiogram, sometimes a stress test. Sometimes we even Doppler the carotid arteries because we have very older donors now in their 70s sometimes, and we want to make sure the blood flow to the brain is good before we take them to surgery. And then depending on their unique individual health history, they might warrant additional tests. All donors have to have current cancer screenings based on the American Cancer Society and the American College of, I think it's ACOG, American College of Obstetrics and Gynecology, their pap smear recommendations for frequency of pap smears, colonoscopy, PSA, which is a blood test for prostate cancer, and any other types of screenings that we feel that that patient would need based on their medical history. So once all of that is done, then the patient is presented to the committee. There's a committee of all of the people that did the consults are at the committee meeting, including the social worker, surgeon, nephrologist, dietitian, financial counselors, coordinators. We have a neuropsychologist who comes to the meeting, all kinds of people that make up the transplant team. And then the coordinator will present the completed workup, and then the team will decide yes or no. Are they a candidate or are they not a candidate? At that meeting, the surgeon at our center looks at the films of the CAT scan. I left off that they have to have imaging of their entire abdomen and pelvis to look at the anatomy of the kidney, how many arteries, how many veins, how many ureters, which is the tube that the urine passes through to the bladder. So we look at the CAT scan, make sure they don't have any other possible, tumors or lesions or anything else that could cause a problem that they didn't know about. Oftentimes, or not oftentimes, but from time to time, a donor will come for a workup, a potential donor, and we'll find something wrong with them that they can't donate, but we actually saved their lives. And I don't know how much time I have, but I have a perfect example. I have a recent donor. She wanted to donate to her son, 68 years old. We did an echocardiogram on her, and they found out that her heart was only functioning at 35%. Oh, wow. Normal is 55 to 60. She had 35 to 40. And then when I questioned her further, she said, yeah, when I go upstairs, I get short of breath, I start sweating, and I have to sit down and I get anxious. So she probably has a blockage in the artery of her heart that she would not have otherwise known about had she not come in to do the donor evaluation. Yes. And unfortunately, she could not donate to her son, but she now has a referral to a cardiologist to further evaluate her. So
that workup probably saved her life.
It probably did.
Wow.
So yes, so that's a basic, in a nutshell, how we do the workup and what's involved. There's a lot involved.
Yeah, incredibly thorough testing.
Yes.
So what happens if you find out they've passed all these tests, but they're just not a match for their intended recipient?
So that happens a lot. We have, you may or may not know that the O blood type, there's 4 blood types, O, A, B, and AB. And so the O blood type is the most common blood type in the United States, and the most common blood type of people who need kidneys. So we have a lot of O transplant recipients waiting for kidneys. And they can only receive kidneys from O donors because O cannot accept compatible. In terms of compatibility, they cannot accept kidneys from any other blood type but O. So we have a lot of pairs where the recipient will be an O, but then the donor is an A or a B or an AB. So, unless you do an ABO incompatible transplant, which we do have a protocol, a lot of centers have protocols where they will do an ABO incompatible transplant, but a lot of things have to be in place, like your antibody titers have to be at a low enough level, you have to get higher doses of immunosuppression, you have to go through some desensitization protocol with plasmapheresis, which is a procedure where they actually take blood out of your body, put it through a machine, remove antibodies, and put it back. So it's a little bit more complex process if you're going to have an ABO incompatible transplant. So, we like to do swaps. And so some centers do internal swaps, other centers do internal swaps, and they belong to organizations like the National Kidney, not National Kidney, the NKR, National Kidney Registry. And so they're into a national registry to try to find a compatible donor. So there's all different ways to do it. Other patients like that will choose to join some other organization that may be able to find them a donor that's compatible. Sometimes we have altruistic donors come forward to start a chain. And then that donor can get transplanted that way, that recipient can get transplanted in that manner. So there's a lot of creative ways. We're always trying to think of creative ways to do incompatible, to help incompatible pairs to achieve their goals with transplant and donation.
Right,
So,
still help those living donors make their decisions.
Since you mentioned altruistic donors,
Yeah,
let's transition to Dan.
Let's
Yeah,
talk to
there you
Dan. You have one of the most unique reasons to donate I have ever heard. Can you tell us about your class and the book you read? What inspired you?
Yeah, so I was a college student at St. Louis University in St. Louis, and I was taking a health-focused sociology class. And in that class, we were assigned to read Mama Might Be Better Off Dead, a sort of grim book about a family, lower-income family, facing a bunch of health disparities. And the author follows this family and different family members, and one of the family members was on dialysis and facing transplant, the possibility for transplant, but then the author goes into these details about how long the wait list is for recipients. And so after reading that, I was like, well, I might be healthy. I should see if I could donate. So a couple months later, in October of 2020, I contacted Barnes Jewish Hospital in St. Louis to see what that process would look like, to get worked up to see as a altruistic, anonymous donor, what that process would be. And then I was put in contact with a donor coordinator and did all of the tests that Anita has referred to. And after 10 months or so, in March of 2021, I donated and set off one of the chains that Anita also referenced.
Wow, incredible.
That's amazing. And
Yeah.
so, you're in this class and you read this book, and you could have just wrote a paper about it to raise awareness. What made you decide to be a living donor?
Yeah, I don't know. I feel like a lot of times I strive for action. I get bored or feel frustrated if people aren't actually doing things, and I think this book really laid out what this disparity looked like, and just thinking of any way that I could actually get involved in that cause, I was motivated to see if I could donate. And then I was getting more and more excited as the tests were positive, and then I was informed that there was a matching recipient, and so then I was totally on board.
Amazing. What did your family and your professor think about this decision? I hope you got extra credit at the very least.
You passed the class with an A.
I did pass. My family was very supportive. I think a lot of people are worried and will mention things which were helpful for my young brain to think about, which is, well, what if someone else in the family needs it? Or I hope to be a dad someday, so what if one of my kids needs it? which is a very real possibility, but I also recognize that as I was healthy and young, that if I were to do it, maybe other people would do it for me or someone else in my family later on. I was also assured that if something does happen with my kidney, that I will go to the top of the wait list, so that's sort of an assurance there. And I think overall, my mom gave the piece of advice that was, well, it seems sort of risky and scary, but I can't tell you not to do something so sort of selfless and nice. So I think everyone was fairly supportive. And then I didn't tell my professor until maybe like a year afterwards, and I emailed him and was just like, by the way, this book did inspire me. And so then he took me out for lunch. So no extra credit, but I got a little something.
Got a little lunch out of it. Yeah, so I'm sure this has been life-changing for you. Tell us how this has changed your life.
Yeah, I mean, perhaps changed my life less than the recipient, but I would say it has changed my life as well. Now I'm seeking to advocate for others doing the same thing. One of the biggest ways that I try to demonstrate that is I run marathons. So I've set myself up for a 50 marathons in 50 states before I'm 50 challenge just for fun. So I did my first one a year after I donated in St. Louis, and now I've done 5 more since. So I've done the total of 6, and it hasn't been a problem. Like, my having donated hasn't set me back in any way. So now I'm trying to use platforms like this, like the National Kidney Foundation. I've gone to DC to advocate with Monica to get representatives to recognize the importance of prevention and creating easier ways to donate and sustainable causes for kidney health. And so yeah, making that a little bit more of my narrative and diving into advocacy.
Wow, incredible. Have you met your recipient? Do you know anything about them?
Not really. So as Anita was mentioning, I initially was put off from contacting my recipient because I met with a clinical psychologist who mentioned some of the time donors feel bad because the recipients want to give them a lot of thanks and give them gifts or just tell them thank you, but feel like they can't give enough. And I didn't do it to be thanked, so I initially didn't contact my recipient. Then after 3 years went by, other people were telling me, oh, you should contact them. So I was curious, and so I did. Didn't hear back initially, heard back a little bit later, and he just said, thank you, doing well. And so that's all I've heard, and that was more than enough.
All right.
That's wonderful.
Thank you both so much for being with us today. We could certainly have this conversation all day. There's so much more to discuss. But thank you for your altruistic gift that you gave for saving someone's life. And thank you, Anita, for all the work that you do in this field and your expertise, sharing that with us, and for all that you've done for me in my life.
My pleasure.
We really appreciate you and are grateful to have had you here today.
Thank you for having
Thanks so
us.
much.
When the Journey Continues returns, we'll take a pee break. Stay with us.
There are 2 types of dialysis, hemodialysis and peritoneal dialysis. The purpose of these treatments is to filter your blood to try to replicate what healthy kidneys normally do. In hemodialysis, an artificial kidney called a hemodialyzer is used to remove waste and extra chemicals and fluid from your blood. To get your blood into the artificial kidney, the doctor needs to make an access point into your blood vessels. This is done by a minor surgery, usually to your arm.
The dialyzer, or filter, has 2 parts, one for your blood and one for a washing fluid called dialysate. A thin membrane separates these 2 parts. Blood cells, protein, and other important fluids remain in your blood because they're too big to pass through the membrane. Smaller waste products in the blood, such as urea, creatinine, potassium, and extra fluid, pass through the membrane and are washed away.
Hemodialysis can be done in a hospital, in a dialysis center, or at home. You and your doctor will decide which place is best based on your medical condition and your wishes. Some peritoneal dialysis can be done with a machine while you sleep, while another type uses bags of dialysate that sit in your belly for several hours before being drained back into the bag and thrown away.
It's important to talk to your care team and loved ones about the different options and considerations when choosing how to treat your kidney failure.
For more information about any of the topics that we discussed today, visit our website, nkfi.org. We hope you'll join us next time, and we'd like to extend our thanks to Donate Life Illinois for making this podcast possible.
That's our time for now. Thank you for tuning in to The Journey Continues. Share us with the people you love wherever you listen to your favorite podcasts, and now on demand on cantv.org, the CanTV Plus app, and the CanTV YouTube channel. I'm Sarah Jane Charles.
And I'm Monica Fox. Until next time, the journey continues.